This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
It's actually on. Okay, we might get started. So welcome everyone. Thanks for joining the first roundtable of 2023. It is pretty exciting to start the year with some wonderful talks, and we've got our speaker today, Prabhakar. I will introduce him in a minute, but I'll first like to commence by acknowledging that we gather on the country of the Wurundjeri people. I pay my respects to their elders past and present, and I extend that respect to other Indigenous colleagues here today. And this country has been a place of learning and teaching and discovery for many thousands of years, much before the buildings of the university were built. And today our speaker will teach us about his own discoveries. But before I introduce our speaker today, I will like you to join me in celebrating the Hub's wins over the past few months while we were in the summer break. So there's been quite a number of papers published, and I will just read the names of the people in the Hub that have published these papers, but then later on at lunch, Janet was very kind to have some printouts, and so we can continue the discussion at lunch. So we've got Amy Thompson and Jason Forty, Electa Schubert, Stefan Bodie, another one from Stefan Bodie, Catherine, and Daniel Furigel. I never say your name, sorry. Then from my own lab, Sophie Lin had a paper, and Elise Rowe as well. Again, from Stefan's lab, we've got Matt Jiwa. Sorry, I probably said your name wrong too. And who else? And we've got another paper from Daniel, Catherine, and Stefan. We've got some completions from Stefan's team, Matt and Helen, Yu, Hong Ko, and Electra all submitted their PhD thesis at the end of 2022. So well done, guys. And last but not least, we had a confirmation in my lab. Josh Corbett had his MPhil confirmation. So well done, everyone, for your amazing efforts. And you should be proud of yourselves, and I'm sure your supervisors are as well. So, to our speaker today, Dr. Prabhakar. So Prabhakar is a neurologist and a professor in the Department of Neurological Sciences at the Christian Medical College in Vellore, India, where he obtained his undergraduate and postgraduate medical training. He then joined as faculty in 2013. He was a visiting professor at the Montreal Neurological Institute in Canada in 2017, where he trained in lesion-symptom mapping, which I believe you might mention a bit about today. His areas of interest include clinical phenomenology, cognitive neuroscience, lesion-based studies, inflammatory disorders, visual neuroscience, consciousness, neuro-philosophy, and critical care. So very broad interests. He's currently a PhD student, supervised by Olivia Carter, says somewhere, Alison McKendrick, and myself. So Prabhakar is on a joint PhD program between Melbourne and Vellore. I always find it very funny because he's a PhD student and a professor and I'm not a professor yet, but I'm the supervisor, so I'm not sure who's going to learn more from this supervision arrangement. So anyway, he spends most of his time in India, but we're very lucky to have him over the next 3 months here in Melbourne. And of course, we're lucky to have him speak today. So thanks, Prabhakar, and take it away, please.
Thank you, Martha, for this nice introduction. So a very good morning to all of you. So I'll be talking about an interesting patient that we came across about a few months ago. And I'll start with little about my background. So I'm from southern India. I work in a large medical school there. Yeah, that's the picture of our medical school. So it's a 2,500 bedded hospital in southern India, and we see about 9,000 patients a day. A regular outpatient, usually I see about 40 to 50 patients a day. So we see a large number of patients, and ours is one of the oldest neuroscience departments in the country. And our collaboration with University of Melbourne is quite historic. So going back to almost 50, 60 years, when Professor Ted Galt from the University of Melbourne came and started our pathology department. And so we've been having a long tradition of collaborations with the University of Melbourne. And as a continuation of that, this joint PhD program was started. The main focus of that was developing clinician scientists, so like primarily doctors, to get them back to do basic research. And that's how I'm here. And my focus is, I'm a cognitive neurologist, and I also work in the field of cognitive neuroscience. I have set up a cognitive neuroscience and clinical phenomenology lab where we look at novel clinical phenomenology of patients and try to describe, understand that through behavioral tests, and do contemporary neuroimaging on them and try to understand the neural basis of subjective human experience. So this is an overview of my talk. So I'll be talking about the role of lesion-based studies in contemporary cognitive neuroscience. I'll be defining blind sight in general, and in particular affective blind sight, because that's what I'm going to talk about. In order to understand the patient better, then we may need to go through a little bit of the theories of blind sight. And because we're going to be talking about affective blind sight, and it involves facial recognition and recognition of facial expressions, I'll be talking about the current models of face processing and the alternative models that are coming up in the theories about it. Then I'll talk about the clinical case description, the behavioral data that we collected for this patient, neuroimaging analysis, and putting it all together, come to some conclusions. So talking about lesion-based studies has been fundamental to the development of cognitive neuroscience. So if you take the case of Phineas Gage and HM, and that's how lesion studies were the founding stones of cognitive neuroscience, where this, so certain brain areas are associated with certain behaviors, and that's how it was understood. And it's important because lesion studies are the only thing that can denote causation, and compared to other functional imaging that are mere correlations when it's done on neurotypical individuals. So the last 40-50 years, lesion studies had died out with the onset of functional imaging and all the contemporary methods. But the last few years, the lesion-based studies have kind of been revived with all the newer methodological, new methods, including functional MRI and machine learning methods, all of which can be applied to single cases as well as to groups of patients. And there's a lot of scope for this. As a clinician scientist, I'm very interested in this because this is the only thing that can start at the bedside and answer bench questions. So I can start with a single patient, and then I can answer basic science questions with that, and that's kind of usually in the opposite direction compared to usual research. So coming to blind sight actually refers to the ability of a patient to correctly respond above chance to any visual stimuli, even though they have damage to the primary visual cortex. To a far extent, they do not have any phenomenological vision, in the sense that if you ask them, they say, I can't see anything. But when you ask them to guess, they're able to guess above chance. And affective blind sight in particular is mainly for recognizing emotional facial expressions. And testing blind sight on a patient is always quite a weird experience, because here you have this person who says they're blind sitting in front of you and you tell them, can you see this? And the usual response is, I can't see anything. And you tell them, come on, just guess. And the usual response is, what do you mean, guess? I'm telling you I can't see anything. And so usually there's kind of this, there's a face-off between the patient and the clinician. And after some time you just tell them, okay, why don't you just try guessing? And then when the patient agrees and you tell them, is it vertical or horizontal? And finally they say, yeah, it's horizontal. And usually you see that the patient, once you tell the patient that they've got it right, they're more motivated to do further tasks. And that's the point when we are able to test these patients. And that's what happened with our patient too. So there are a lot of theories of blind sight. So the primary thing is that the primary visual cortex, V1, is essential for conscious awareness of visual stimuli. So if that gets destroyed, so you will not have any phenomenological vision, but patients do very well on certain other tasks. May it be recognizing objects, or may it be emotional stimuli, maybe color, maybe motion. And it varies from patient to patient depending on the extent of the lesion and the time in which you are testing them. So, but blind sight happens because visual information from the retina is able to reach the visual association areas in the extrastriate cortex by bypassing V1. And two dominant theories exist. One is the lateral geniculate theory, where the lateral geniculate nucleus, which is the primary efferent of all retinal input, which projects through the V1, also projects through the extrastriate areas. And if these projections are spared, then it's possible that there could be some information that goes to the cortices and they may be having blind sight. The other theory is that information from the superior colliculi, which gets in fact it gets multimodal information, and not only from vision, that projects through the pulvinar nucleus, and the pulvinar is known to project to both parietal cortex as well as the temporal cortex, and maybe even to the frontal cortex, and that way it can convey information. So, and there's been a debate about these two theories, and because we're going to be talking about affective blind sight, I'll go over the current model in which face processing is understood. There are two ventral areas in the brain and one dorsal area in the brain that is involved in face processing. So early visual cortex is primarily V1, and from there visual information can go to the inferior part of the occipital lobe, which is primarily involved in picking up parts of the face, and the holistic aspects of the face is picked up in the fusiform gyrus. And this is more on the right side than compared to the left side. And there is a dorsal area which is in the superior temporal sulcus. It is in the upper part of the temporal lobe where it meets the parietal lobe. And this is involved primarily for moving like dynamic aspects of facial expressions. So moving eyes, moving facial expressions. The superior temporal sulcus is selectively activated by that. And of late there are more theories saying that there may be an additional pathway other than the dorsal and the ventral pathways in vision, which can bypass the ventral areas, and visual information can start in the early visual cortex through area MT, can directly reach the superior temporal sulcus. And in primates and in animal models, people have demonstrated the pulvinar nucleus also projects through this superior temporal sulcus. So this is a background in which we can actually ask certain clinical questions and ask. So if you look at affective blind sight specifically, so we know that visual information comes from the superior colliculus and then it reaches the pulvinar, and there are two dominant theories, both not mutually exclusive, that visual information reaches the superior temporal sulcus or it reaches the amygdala, and both of which are involved in processing facial expressions. And however, there's not much literature on which is the dominant one. So in this background information, then I will just take you through the history of our patient that we came across. So he is a 58-year-old farmer. He's actually from a neighboring country, and he had come to us almost 6 months into his illness following visual loss. So his symptoms were that he woke up one morning, he was walking to the washroom, and suddenly he sees this flash of light in front of him. This flash of light was more on towards his right side, and it was white, diffuse, and it was kind of flashing for a few seconds, and then blank. After that, he describes everything goes blank, he can't see anything. And he's already had a stroke before, so he's kind of walking with a limp before that. But after this, he had severe difficulty in navigating, he couldn't see anything, and he was brought to us saying that he can't really see anything. So at the bedside, we tested him and we found that his pupils were normal and reacting to light. And this means that his retina was intact. And we did brain imaging and we found that he had bilateral occipital lobe infarcts. So in order to understand him further, so we went on to talk to him a little bit more and ask him about his visual experience. So while talking to him, we realized that in the right inferior quadrant of his field, there was a small island of vision. And any formal testing of visual field was not possible because it takes almost 3 to 5 seconds for any stimuli to, for him to have phenomenological awareness of it. And within the next 2-3 seconds, it kind of just vanishes. And this was so because of which any formal field testing could not be done. But so while we were testing him, another interesting thing is that every few seconds, my face would just pop into his conscious awareness, and he'll just look at me and smile, and then he'll say, it's gone, it's gone, it's gone, and then we'll go on with the test. And then periodically our behavioral testing will get disrupted because suddenly he'll get awareness of something else that happens in front of him. And for people who are interested in consciousness, it's something that's really fascinating because, so we tried this, so we tested him in that particular area with multiple stimuli, and we found that things that were red lasted longer. It lasted about 11 seconds, while other colors lasted only about 3 or 4 seconds. So that part is, we have not, so I'm answering only one clinical question that came out of this whole ocean of phenomenology that we saw in him. And I'll take you forward and I'll take questions on the other things that he had. So when we did a visual assessment, we couldn't do any formal visual acuity because when we switched on a torchlight in front of him and asked him whether if it's on or not, he's not able to guess. So when we ask him to guess whether it's, is it on or off, which direction it's coming from, he's not able to guess except in the right inferior quadrant. So we wanted to assess both his ventral stream function as well as his dorsal stream function. So the ventral stream function, we normally, the bedside thing is to just show him some line diagrams of objects and ask him to name it. And if he can't name it, then we would suspect a visual agnosia, then we would ask him to match objects. And if required, if he's got deficits in this, then we would do more gratings or more complex stimuli, which are more scientific. So the bedside thing is just to do with simple line diagrams of meaningful objects. And we found that he was not able to recognize objects, he was not able to recognize color. And surprisingly, what we did is that he was able to guess motion. So he couldn't guess light, but he could guess when your hand was moving versus not moving. On almost 100% of the trials, he was able to guess correctly. And we couldn't even call it blind sight because he got, there was no forced choice, and every time he was getting it right. So it was something like a dissociation. So he was able to perceive motion. The other interesting thing that we found is that you leave an object next to him, if he can just reach out and pick it up without knowing what the object is. And we also found that his hand pre-shapes to the shape of the object very accurately. And so to us it looked like his dorsal stream function was preserved while the ventral stream was completely gone. And the other thing that we did in him is that we asked him to imagine in color, and mental imagery is something that we study in most of our patients with higher order visual loss. And it's well known that even if you have damage to the primary visual cortex, it's possible to have intact mental imagery. And we found that some of these patients, if you have your visual association areas that are involved, you will only certain selective deficits in mental imagery can happen. Like in our patient, he was able to imagine objects in motion, he was able to imagine object, but he was not able to imagine objects in color. Like if you ask him to imagine an apple, so he used to imagine it in gray and it had lost color, even in his mental imagery. Yeah. So of all of these, we were quite, the other interesting thing that we found is there was a dissociation between recognizing faces and facial, especially there are two ways that we assess facial recognition in our patients. One is a static emotion where we show them a picture of facial expression and they have to guess the emotion. And the other is a short video clip which selectively is supposed to involve the superior temporal sulcus. And we found that he was making mistakes with static emotions, but dynamic emotions were preserved. And so going on, we decided to do a battery of behavioral tests on him to understand his visual phenomena. So we wanted to know whether he had visual agnosia. So we gave him a list of object naming task where we show these line diagrams, and we found that he was not able to guess any of these, he was not able to name any of these, and whether there was a stimulus or not, he was not able to tell us at all. And even though they are not able to recognize the object, they may be able to match objects, and that is called as associative visual agnosia. And to check for that, what we do is we do an object matching task, and he failed in that too. So we knew that he had no phenomenological object perception. He could not perceive light, but he could perceive motion. So we tried with color, and we found that he was not able to name colors. Again, color naming deficits could be because of a color agnosia, which is aperceptive, where you can't see color at all, or you can see colors but you can't associate it with meaning, which is called an associative color agnosia. For that, we do a color matching task, and even in this, he tended to do badly. Surprisingly, as I already mentioned, that when we did in the lab, we did a motion direction discrimination task with a random dot kinematogram. He did perfectly well. He got almost the same as our neurotypical individuals. And going on to the interesting part, so while we were doing this, then we finally decided to test him on facial recognition tasks. And this task, most normal neurotypical individuals would never get anything wrong, because here all you have to do is say whether the face is jumbled or not. And we found that he was not able to differentiate a face from a jumbled face, and he did pretty badly on this task. And when we did static emotions, he was slightly better, but he was still not able to recognize the static facial expressions. But when it came to dynamic facial expressions, in the blind field, he was not able to recognize it at all. But when we did a 2 alternate force choice, then he tended to do better. So going on to the results, this was mostly done in the preserved field, and it took almost 2-3 days to do it on him because his attention was limited. So we had to do single trials, and there was always a person monitoring his eye movements, and if we found that he was inattentive, or he was looking somewhere else, or whether he was using his blind field, then his preserved field, we would cancel those trials. And after that, we found that in this preserved field, at least, we found that his ventral stream function was completely gone. His static emotion recognition was impaired compared to neurotypical individuals. And what is shown in green is what is preserved. And we found the 2 things that were preserved. One is the dot movement direction, and the other was of dynamic facial expressions. And so now what we did is that we also did, and I forgot to mention that the jumbled face task, what normal people would get 100% right, 100% of the time, he was getting only about 22% accuracy, which is much below chance. So what we did is, now we decided to do all of this as a 2 alternate force choice paradigm, where he has to guess. And initially coaxing him to do the task, we finally managed him to cooperate, and this is what we found. So few things improved so much dramatically when we gave him a 2 alternate force choice. Like object naming didn't improve at all, and face gender identification didn't improve at all. Not shown here is also the jumbled face task, even that didn't improve at all. But what did improve was his color naming task improved, his facial expressions recognition improved, and all of this was above chance, saying that this gentleman definitely has an evidence of blind sight, and blind sight was mainly for color and as well as for dynamic facial expressions. So as a neurologist, I was quite keen to understand what was the neural basis of all of these phenomenology that we were seeing. So we went ahead and did first a clinical MRI. What is seen here is T2 weighted, you can see the T2 weighted MRI slices in the upper cuts, and it's showing bilateral occipital lobe lesions. The right V1 was completely destroyed, and the left V1 was partially destroyed, and it was in the left side, it was extending into the parietal lobes. So as part of the research study, what we did is we normalized his MRI into the template brain, and we mapped out his lesion. And the advantage of mapping out the lesion is that then you can apply it onto a standard template and take data from functional imaging studies, atlases, and we can incorporate multiple things into a single patient's data. And so what we did, the other thing that we did is what is a lesion network mapping. In a lesion network mapping, what we do is we take the mapped out lesion and take a large data set of a resting state fMRI data set, and we use this lesion as a seed, and understand in normal neurotypical individuals what are these areas connected to. So, and we do a statistical thresholding and we find what are the significant areas this particular lesion is connected to, and that is called as a lesion network. So we also did a tractography, whole brain tractography in this patient, and you can see that the bilateral occipital area, there were a lot of loss of white matter tracts. So answering some questions in this patient. So this patient could not see color at all, and in fact even his mental imagery was impaired for color. And what is demonstrated here is the data from the Wang's atlas that is overlapped with the patient's lesion marked in red, and you can see that the lesion extends to bilateral V4, and this is probably the reason why this patient was not able to recognize color. So this makes me wonder, what about motion, because motion, he was able to perceive motion completely well, and so we needed to demonstrate a dissociation, and that's what we did. So we mapped out from the same atlas, we mapped out the probabilistic maps of the area MT and MST, and when we looked at the lesion, we found that the lesion seemed to be sparing area MT and MST. So that we were able to demonstrate a kind of a dissociation in this patient between the visual, the movement pathway and the color processing pathway. Because the primary focus of this talk was effective recognition, facial expression recognition. So this slide actually shows the facial recognition and the areas of the face, areas of the brain that process face information. What we found is the fusiform face area was not directly involved by the lesion, but despite this our patient could not recognize facial expressions. The occipital face area was partially involved by the lesions bilaterally, and maybe that could explain. And one thing that was preserved was the posterior part of the superior temporal sulcus was preserved bilaterally. But in his central field and even in the preserved field, we found that he had significant impairment of recognizing static emotions. So we were quite intrigued. We wanted to see whether if it cannot be explained by the lesion, can it be explained by the lesion network? So what we did is we mapped out his lesion network and put it on the template brain, and we found that his lesion network extended much more beyond V1, and we found that it involved both the fusiform face area and the occipital face area, but even the lesion network continued, spared the posterior superior temporal sulcus. And as we saw earlier, the STS receives projections from the third visual pathway, which can bypass the ventral stream. Also it can get information from the pulvinar nucleus. So we wanted to see whether we could analyze his resting state fMRI data and see whether we can get some evidence for this. So what we did is we took some regions of interest. We took the pulvinar nucleus as a seed, and what we did is a seed-based correlation, and we mapped it all onto the same template brain. And what is shown in red is the lesion network. That means that's not only the damaged V1 but the extent of the lesion. And what is shown in bluish green is the connectivity map of the pulvinar nucleus. And what we can see is that there's hardly any overlap between the pulvinar's connectivity and the lesion network, and there is direct projections from the pulvinar nucleus to the STS bilaterally. And our hypothesis is that these connections are the ones that facilitate blind sight in this particular patient. And the connection from pulvinar to area MT has been studied widely by the group that studies blind sight, but pulvinar to STS has not been studied as much before. So this is a novel contribution to this field of blind sight. Of course, there are primate studies that go back to the 80s and 90s that say that there are connections from the central pulvinar nucleus, and they have postulated that it may be involved in recognizing facial expressions. And so there's been a huge gap in lesion studies in this. So we also did a resting state fMRI on our patient, and we analyzed the functional connectivity. And this connectivity matrix shows the results of the second level analysis, where we compared we took certain ROIs of all the face processing areas, and we compared it with a group of neurotypical individuals, and we found that the connection from the pulvinar to the preserved FFA and bilateral STS was strengthened compared to the other connections. We also looked at the LGN here, and we found that there was not much increased functional connectivity compared to controls. So we were getting more evidence to say that the pulvinar's connections to the phase processing network somehow seems to be strengthened in this particular patient, contributing to blind sight. So we also did a graph theoretical analysis using all of these measures, and we found definitely compared to neurotypical individual, our patient, the facial phase processing network had altered connectivity, especially in certain measures, like if you see the pulvinar came up significant on global efficiency, local efficiency, it had an increased clustering coefficient, and the STS had again measures of increased connectivity, which is the degree and betweenness centrality. So our conclusion was that the pulvinar's connections to the STS, we were getting both direct as well as indirect evidence to say that was contributing to blind sight in a patient. So in conclusion, so we were able to demonstrate blind sight for color and facial expressions in our patient. So our hypothesis is that the preservation of the posterior STS is probably contributing to the phenomena of affective blind sight, and also the dissociation between dynamic facial expressions and the static facial expression. And overall, even though it's a single case, our patient findings support the pulvinar theory of blind sight, especially when it comes to affective blind sight. Yeah. Thank you. Happy to take questions.
Thank you. That was a wonderful talk. So, questions?
So great job. Actually, I think I missed something in your slides. So I just want to confirm the patient can recognize the like a manipulation in the dynamic, task. So he can recognize the things.
Yeah.
Dynamic.
Yeah, so he is able to recognize all like motion related tests he was able to guess. Like one was the simplest thing that we did was the random dot kinematogram, where a collection of dots move in one of the four directions, then he was able to guess that. And for the facial recognition task also, so what we had to do is we had a 1.5 second video which we had to loop. So normally for normal neurotypical individuals we don't loop the video, so they just see the stimulus once. But for him, because his attention was limited, we had to keep playing the video continuously till he was able to respond.
So I just want to make sure if the dot task, he can locate the change. For example, if the task dot one is here and the dot move to the second position, so he can recognize this thing.
No.
So just perceive the movement.
He was able to guess the direction of the movement. So it's not individual task. So he was able to guess the coherent movement of the dots.
Is that possible? It's just the learning effect. Because, if he can, for instance, I was thinking he can recognize the dot movement, like moving from A to B or B to C or C to D. So I was expecting this one to do dot.
Yeah. So these dots are very short-lived. So each dot individually lasts only about 22 frames of the screen. So these are like random dots that pop out, and it's just the direction that is coherent. So it's not possible to actually follow individual dots in this particular task. So.
Natalia?
Thank you very much. Very interesting talk. I have a question about the temporal aspect of it. So I've noticed that the reaction times for quite slow, and then you also mentioned that it takes several loops to recognize the motion. I'm just wondering if you were, again, to not do MRI or do something temporal, so can you comment on perhaps how the indirect connection, not through primary but through higher levels, affect the timing of things? And again, more on what you were saying about him recognizing things in 3 seconds and 11 seconds. So just a little bit more on the temporal picture.
Yeah, so one thing is that in him he was somebody to get his attention, so it was more of a clinical problem rather than actually a scientific problem. So to kind of getting him to sit and focus, and so he was somebody who's had his 2 strokes, he's quite disabled by the stroke, and kind of encouraging him, so you had to kind of encourage him to pay attention. So after a couple of trials he said that I had enough for today, and then so that's why the reaction times are like quite a lot. So this is after excluding a lot of trials.
So you would guess that it has nothing to do with the timing of.
No, I would think that his information processing speed is definitely much. he takes much longer to process information. Like going by his subjective experience, so if a stimulus is popped in, it takes about 3 to 10 seconds to appear in his consciousness, and it wanes off immediately. So that could be one of the reasons. And one of the reasons that we kept playing our stimuli is that we don't know when it reaches conscious awareness for him. So we displayed our stimuli till there was a response from his side, and that's why it took up to 30 seconds in some of the tasks.
I'm just wondering if some temporally resolved methods would be a good way to try with this particular patient.
So we could have tried EEG and other things. So
just to basic tasks with EEG to see where it happens.
I think that's a good idea, and unfortunately he's from a neighboring country and he's not come for follow up after that. So but subsequently with other patients we should get an EEG also done.
Thank you. Arsha?
I was wondering if you have access to TMS fMRI potentially, just to look at, because it could be potentially very interesting to see if, for example, inhibiting the posterior SCS would modulate the connection with the pulvinar and have impacts on the emotion.
So I think it's a good, good suggestion. Is something that subsequent patients, because we do have TMS and it's possible that we could inhibit.
Daniel?
Yeah, thanks for a fantastic talk. It's so nice to see characterization of an individual like this as well. I just had maybe sort of related to some of the other questions about the performance on the dynamic face task. So one of the things you highlighted was that for motion and direction and things, they were very, very good at judging this. And one thing that we encounter with face expression experiments is usually that people will use all sorts of low-level cues. So even how wide people's eyes are when they're surprised or something to be able to do the task without necessarily like comprehending the emotion. If you like. I was wondering if any of your neuroimaging results might speak to sort of the involvement of those sort of motion-related things. So are they exploiting those cues to maybe be able to do this task a bit better than they would otherwise be able to do?
So that's something that it's theoretical. We couldn't address him. Like for example, he did have limited visual attention, so we didn't know whether he was. So eye tracking would have solved that, because so we didn't know whether he was looking at the face, the entirety of the face, whether he was paying attention to only the upper part of the face and getting, like for example, the difference between anger and disgust may be just the upper part of the face. So those are things that if we had eye tracking would have helped us, but those are things that we have with neurotypical individuals. For this particular task, we find that a lot of, in fact, the average neurotypical individual for this task in our lab is about 65% only accuracy. So a lot of normal people also get confused about certain emotions, especially in our population. We find that people don't get disgust so easily. So.
Fair enough. I guess if you do have the data, it would be nice to even compare. Maybe you've done this, the confusability between different expressions for the patient compared to the controls to see if there's patterns. If the patient is also finding disgust particularly hard, I think those would also, provide a really good template to show that it's similar, or if there is any differences with.
I think I have the data, and we can look at that.
Thank you.
Saga.
Thank you, Prabhakar, for the fascinating talk. A lot of questions are popping up, but most of them you have already answered. But a couple of questions I have is that, there is an alternate, the pathway from the geniculate, which is bypassing V1, going to dorsal strain. That's throughout the color, it's mostly S1 carrying signals. Did you look at that specifically? The S1 signals are better represented. And the other one is intriguing. Why the when they can see your face, why does it happen only for a few seconds and then disappear? And why is that red color still there, still somehow preserved?
So I'll take the first question. So one of the things is that the connection to the lateral geniculate. So we were not actually, we were just looking at seed-based correlation based on resting state fMRI data, and we were using what is actually an arbitrary statistical thresholding technique. So in this method, we just take a random value of say 5, and but for subcortical structures, people say that you can use lower thresholding, and if you do that, we would find that there's probably connections to the amygdala and to the parietal cortex as well. So we are not actually particularly looking at one particular group of neurons in this method, and
I'm just wondering why when they can see your face, it appears only for a few seconds and then it disappears.
Yes, sir. So that part would be probably related to it's not so much to do with blind sight, with theories of consciousness per se. So whether it goes along with posterior theories or whether it goes along with the global workspace theory. So it looks like any salient stimuli at some point in time reaches his conscious awareness. When it reaches, and it of course depends on his attention and whether he's able to pay attention to it. And the moment he's seen it and if he has no major thing to do with the particular object, quickly it kind of goes off. And red is known to be a salient stimuli. Normally at bedside clinical testing, in fact we use a red pin to check visual fields. And that was one of the reasons probably red had a more salience and it lasted much longer. And
just going to follow up on Saga's question about color. I wonder if you tested for purple as well. And the reason I ask is because there's been a suggestion that purple goes subcortically rather than cortically. I don't know if that's been replicated, but there was an initial study suggesting that, and which could, I'm not sure if red is also would also travel subcortically more so than cortically. I don't know.
So our regular color naming task does have purple in that way. I could look at the data and see whether there's a difference. So
I had a more general question about, so obviously you demonstrate a pretty good case that there is pulvinar to STS transmission of information, but of course another prominent theory involves the amygdala, but your data didn't really show any, at least the resting state, if I understood correctly, didn't really show anything above and beyond. So do you think it's something specific to this patient, or do you think maybe
so one would be a methodological issue. So like I would think that because the standard statistical thresholding that for cortical structures is a t-value of 5 or 9, and it's still debated in the lesion mapping literature. And when it comes to subcortical structures, some people have used threshold as 2 as well. So if you change the threshold, then I had got connectivity to the amygdala as well. And with higher thresholds, I'm not getting so that's something, maybe a limitation because of the methodology itself.
So it might be that both are actually...
both are actually involved. But neuroanatomically speaking, if you see the pulvinar and the STS are very close to each other, and the amygdala is pretty far away. And as a neurologist, I would think that why go all the way to the amygdala when you can directly go to the STS?
Yeah, that's a good point. Yeah, but what about myelination? Would that are they equally myelinated? Because if there was...
So that's something that we can look at, and we just started doing T1, T2 ratios. And unfortunately, I think I had a discussion with you, and we started doing it after this patient had left. So now we do T1, T2 ratios for some of our patients.
Yeah.
Yeah.
Right. Jay.
Can I ask, how long post-stroke was the patient? Was there do you think there's any plasticity involved, or was it quite certain post-stroke that you were seeing?
Yeah. So this patient was 6 months post the stroke that involved the occipital lobe. He also had a stroke in his internal capsule at about 18 months ago. So he's had 2 strokes. So there's a lot of room for neuroplasticity in him. And what we are seeing is actually after almost 6 months into his stroke, where there's been enough time for a lot of neuroplasticity.
Yes, I'm just wondering if maybe, what you put forward sort of supports the pulvinar hypothesis, but does it necessarily exclude the possibility that this is just one possible neuroplastic pathway that could be created, and other possible neuroplastic pathways could be created in different individuals?
I would think that they're not both mutually exclusive in the sense that it may vary from individual to individual when the extent of the lesion and how much the phenomenal, and also it depends on the task that you're testing them at. Like for example, if you're testing them for motion, maybe it's possible, I'm just hypothesizing the LGN to MT pathway may be more important, but for facial expressions, the pulvinar pathway may be more important. And the timing, there's a lot of thing in literature saying that plasticity is one of the things that contribute to it, and it's maybe the time in which you're testing. But not this patient, but recently, like just before I got here, we had a patient with blind sight who, from day 2 of his stroke, we were able to demonstrate blind sight. So we had actually gone and demonstrated blind sight in the ICU in him. So with a laptop held up above his head, we were able to test him, and so we have sequentially tested in him. So saying that, so timing may not be, so I would hypothesize saying that these pathways are existent. Maybe they are contributing to normal perception by contributing to feed forward loops directly, and they take over later when there's a damage to V1.
Did that patient's blind sight evolve over time? Like, did it change the nature of it over time?
Yeah, so that patient had blind sight for motion and for facial expressions initially, but after about a week, the blind sight for motion kind of went off, but the facial expressions persisted. So
it was just a recovery pattern?
Yeah, it was a recovery pattern.
Just going to follow up on Jay's comment about plasticity. I thought you said that he had a damaged hemisphere but a preserved one. Is that right? Because if that's the case, then you could see whether there is increased connectivity in the damaged hemisphere compared to the preserved one.
Yeah.
This is something that others have done, like
so even in our resting state data, we found that the left FFA from the relatively preserved hemisphere had increased connectivity with the STS bilaterally. So the plasticity was not only in the
it wasn't only in the damaged one.
Damaged hemisphere, it was actually extending into the opposite hemisphere as well.
Oh, fascinating. Any more questions? I think we've fed for thought, and then we'll be feeding our other brain. So it will be in Peter Hall rather than here. I'm just going to wait for Janet because she knows where to go, and then we're going to follow her. She should be here in a minute. But yeah, thanks again to Prabhakar. That's great.
Thank you.
Thank you so much. I did have one question that it's maybe I've misunderstood. There is in your slide you had for static motion. They had the patient was about 77%, and yet you said it was not preserved.
It was 67. Like what we find is the normatives, like static emotions, cutoff values is around 75 to 80, and most people get around the mean is around 80 to 85. So we have about 200.
Because for the dynamic one, it was even slightly lower, but you consider that to be preserved.
What we found is that in static emotions, it's the normative data is skewed positively, more towards, and our cutoff values are much higher.
Oh, I see. Okay. But I suggest when you're presenting that
to normalize it.
To normalize it or show what the cutoff is. Okay, that makes sense. Yeah.
I'm pretty sure this is a photo from Doug because Peter was his building and he says, so is this your
it's
group?
there.
So
All
I
right.
think that we are just going there.
Okay, perfect.
I know where it is.
You know where it is. Okay.
Yeah.
Oh, there's Janet. So if you don't know where Peter Hall is, you can follow Janet. Okay. And that's how you know. I think it's just me. Shall we meet there? Brad, do you want to
I've already done a lot. Yeah, it's fun to finish his PhD.
I know, exactly. I think the challenge was
I'll see you tomorrow.
to choose. Yes. So you want to join now?
No,
you have to go.
I'll
Yeah.
go back.
Yeah. Okay. Good luck with your meeting.
Wonderful talk. Thank you. Very good. Thank you. Very fun. Okay, sure. Bye. Bye.
Yeah.